Apology members for the technical hitch. Dr. Boston, please proceed with your presentation. Thank you. It seems like Dr. Boston has dropped out again. Yes, welcome back to Dr. Boston. Your hand is raised up. Please proceed.
Thank you. I think I had finished. I don't know if you are hearing me.
Yeah, we can hear you.
Yes, I'm saying I had presented. I don't know if you were hearing me that time.
You were very audible until we got disconnected, but we heard you.
I don't know where you got disconnected because I had finished and handed them over to you. I finished with HPV.
I think the finishing part, we got lost. Probably you can wind up in a summary so that we catch up with you.
Okay, so summary. So number one, malaria vaccine expansion and switch. Why is it there? We are expanding because more and more supply available vaccine is coming, or there's more available vaccine that has been assured. Why are we switching? We are switching just because there are now two products, and the second product that has come in, there is assurance of stable supply. So because of that, that's why you want to make sure that you go to a product that you are sure to have it. It's more predictable. However, in terms of their effectiveness, is the same. Efficacy is the same. They have similar product safety profile, but also their cost effectiveness. In terms of IPV2, the reason why we're introducing IPV2 is because it's part of the polio endgame strategy. We want to ensure that we're able to meet these two objectives. Number one, to interrupt WPV transmission. Number two, to also stop circulating vaccine-derived polio viruses. And we know circulating vaccine-derived polio viruses, which are also called vaccine variants, they come because of the use of oral polio vaccine. Now, you want to make sure that by the end of the day, we have immunization program that are using inactivated polio vaccine so that you prevent from vaccine-derived polio viruses. In terms of HPV, maybe before I go to HPV, I also mentioned that in other countries, in other setup where they don't want to introduce IPV2 as a separate dose, there's another vaccine which is multivalent, what we call hexavalent. So hexavalent, it's a vaccine that contains 6 antigens: diphtheria, tetanus, pertussis, hepatitis B, Haemophilus influenza type B, and IPV. So because there's already IPV component, it means children in those population or countries, they are able to get IPV containing vaccine at 6 weeks, 10 weeks, and 14 weeks. As such, they do not need to have monovalent IPV. However, the supply situation for hexavalent is not yet stable. That's why countries are now going straight to monovalent IPV. In situation or in the future where there'll be stable supply for hexavalent vaccine, I'm sure many countries will switch to a hexavalent because that will be user friendly, easier, but also programmatic. In terms of programmatically very suitable, as one antigen one vaccine contains 6 antigen. Talking about HPV vaccine, switching from 2 doses to 1 dose, mainly because strategic advisory group of experts on immunization reviewed data that showed the use of 2 doses in terms of effectiveness of 2 doses is as good as effectiveness of 1 dose is as good as effectiveness of the same vaccine for 2 doses. So because of that, actually, with available evidence and data, that's why countries are advised, are recommended to switch from 2 doses to single dose. So this is more cost effective, easier to implement, but also we can catch as many girls as we can. However, in a population that are immunocompromised, for example, maybe they're on immunosuppressive drugs, or they have maybe primary immunological diseases, or they have condition like human immunodeficiency syndrome, HIV. The recommendation is that in this population we need to use 3 doses. The reason is individuals with challenges with immunization, primary immune issues, they are not able actually to produce the desired immune response to protect them from the disease. So you need several doses to push the immune response so that they can produce enough antigen that can protect them from the disease. So that's it, Christine and colleagues. We'll be happy to take questions at the end of the session. Thank you, and over to you, Christine.
Thank you very much, Dr. Boston, for that simplified, elaborated talk on the global, the WHO position in the switch, the expansion. It has been very clear to us as to why we are carrying out this as a country. I want to remind members that we shall have a Q&A session at the end. So please put your questions on the Q&A session and we will continue. Our next speaker is going to be Dr. Collins Tabu. Dr. Collins Tabu is a health specialist at UNICEF, Kenya. He has served in UNICEF since April 2022. He plays a vital role in supporting the development and planning of immunization programs, ensuring they align with the global strategies. And an example is the Immunization Agenda 2030 and the Gavi 4.0. Prior to joining UNICEF, Dr. Tabu was the head of National Vaccines and Immunization Program. And there he was able to lead initiatives in including the rollout of malaria vaccine in the country, HPV vaccine, and even COVID-19 vaccination campaign, aiming to protect vulnerable populations and improve public health outcomes across the country. With all that experience and knowledge, he will be able to speak on the rationale for the HPV vaccine, malaria expansion, and IPV. Karibu sana, Dr. Tabu.
Thank you, Christine, for your kind introduction. Colleagues, ladies and gentlemen, I appreciate deeply the opportunity to speak to you this evening on the 3 or rather 4 vaccine initiatives that are ongoing. Most of what I would otherwise speak about has been spoken about by my colleague, Dr. Boston Zimba, and as we were preparing together. He went through the rationale ably of the IPV2. I don't think I want to go back through that, Christine, if you allow, in the interest of time, and the malaria as well. What I want to touch on a bit more, and especially within the country context, is the HPV vaccine switch from the 2-dose schedule to the single-dose schedule. But before I do that, just observe that unlike other audiences, I'm privileged today to speak to the converted, so I'll keep it a bit simple, but also welcome a lot of your reflections, guidance, from which we may also be able to learn, really, to advance the program within the country. So all of the vaccine switches and vaccine formulation switches and the new vaccine introductions are geared towards few objectives. The topmost underlying objective is to achieve the immunization program optimization within the country. One, doing this even as we maintain really the highest level of protection for our populations and our children, even as we assure the highest level of coverage by not introducing unnecessarily new visits, but even also as we maintain our focus on disease elimination and disease eradication. Boston did say we are very close enough to eradicating polio. Together, we all can be able to do it. Why vaccine program optimization, especially for the three, is while we're introducing the IPV2 to protect our children from polio, but also to move a step closer to eradicating polio. The other three components, the other two components of the malaria vaccine and the HPV vaccine are much more focused towards immunization program optimization. A switch to a single dose from a two-dose vaccine formulation, one, portends a lot of economic benefits for the country. HPV is the second most expensive vaccine after malaria. Population-wise, it may be a bit less budget-wise because you're just vaccinating half the population. But given the costs that go to the HPV and given the recent knowledge, some of it from our setups, research from our setups showing that indeed a single dose of HPV has the same level of efficacy as a two-dose schedule of HPV, this is critical. And again, the evidence showing that the duration of protection from a single dose of HPV to a two dose of HPV is comparable, really gives a lot of comfort for us to be able to, and alongside, of course, the WHO surgery recommendations, to be able to consider switching from a two-dose schedule to a single-dose schedule, where I would have cost savings that can be used or plowed back to reach more children. A single-dose HPV schedule also promises to maintain or reach a higher coverage, because then our adolescent girls do not have to come back for a second time to the health facilities, or we do not have to bear the costs of going back to the schools to reach them, processes within which many girls are otherwise not reached. As they come to the health facilities, remember, caregivers have to spend an extra time or coin to bring back the children or the adolescents for vaccination. So this is critical, not just a savings overall to the program, but also to the society, to the community. But so why HPV? Now, HPV, the human papillomavirus is the main cause of cervical cancer. We have about 100 different types of HPV viruses, out of which just about 13 are considered oncogenic, like they cause cancer. But out of these 13, the serotype 16 and 18 cause more than 70% of the cervical cancers that we do have within us. We have about 2,300 new cervical cancer infections every year, cases every year, diagnosed every year. This is reason for us to worry. We have about 1,600 deaths of from cervical cancer every year. We have to worry more because this means about 5 women die daily from cervical cancer. It gives us a lot more impetus for us to be able to prevent or protect ourselves from cervical cancer. As we do this, we are not doing it in the dark, but we're aiming for a 90-70-90 target, that we aim for 90% coverage of the HPV vaccines among adolescent girls, the journey on which we're still focused on and which is reinvigorated by this opportunity to switch to a single dose HPV vaccination schedule, that we do hope to screen at least 70% of all women between the ages of 35 to 45 years for cervical cancer, precancerous lesions, but 90% that we do hope to reach and treat at least 90% of our women who show evidence of precancerous lesions. So it is a bigger journey. Like Kristen did say, we did introduce the HPV vaccine in 2019. We have seen tremendous progress, not just vaccinating the children, but availing as an opportunity to reach these adolescent girls with other services. You may well be aware about the other programs and period, stigma and all of that. So ladies and gentlemen, without belaboring the point, without going into a lot of science and without talking to you about that which you already know, and noting that we barely have another 20 minutes to allow more time for interaction and more focused Q&A, I would like to pause it there and appreciate our host, Christian Miano. Over and back to you. Thank you.
Thank you, Dr. Tabu, for the discussion on HPV vaccine. I've seen questions concerning HPV vaccine, and I know that on the Q&A session, you'll be able to also address part of it you've also talked about. Our next speaker, we'll have Dr. Wesley Mugambi. Dr. Wesley works with the Ministry of Health, National Vaccines and Immunization Program. He is a clinical pharmacist with 13 years clinical work experience and 2 years working with the National Vaccines and Immunization Program. So he will speak about national vaccines and immunization plans. Currently, what are they doing? What are the preparatory activities that are taking place for the 3 antigens? Karibu, Dr. Wesley.
Yeah, thank you. Thank you very much, Christine. If I can be allowed to share my screen.
Yeah, we can see a presentation. So you can start with the first slide and then put it on slideshow.
Let me know if that is okay now.
Yeah, it is visible from my end.
Oh, okay. So thank you very much, colleagues. And I think it is important for us to really commend you for, holding on. We have had, I think, two mishaps with the technology, and I still see quite a number of people joining in. That means that we are really eager to know what is happening with the vaccine situation in the country. So thank you so much. Now, like I was introduced, my name is Dr. Wesley Mugambi. I work with the National Vaccines and Immunization Program. We have been doing quite a lot of work with the vaccines, and I think we had a webinar not so long ago in June, July, where we were introducing a new vaccine, TCV, that is a typhoid conjugate vaccine. I think it would be important for us to mention here that the introduction was quite a success. We did roll out the vaccination at the age that is supposed to be now given at the age of 9 months. And we are expecting that going forward, we are going to be having good coverage when it comes to typhoid prevention against typhoid amongst our children aged 9 months. Now, it is important for us to always highlight that we do quite a lot when it comes to prevention of vaccine preventable diseases. And on the screen is the number of diseases that we immunize against. Cumulatively, they are around 20. We do give quite a few in combined doses of vaccines. Now, my work is going to be easy because I think most of these points have already been alluded to by the previous two presenters. We talk about HPV in relation to cervical cancer, and at times I think we most of our people out there, miss out on the point because it is difficult for them to marry the relationship at times between HPV and cervical cancer. Now, HPV, like Dr. Tabu said, did mention, is responsible for causing more than close to 75%, 70% of the cases of cervical cancer in the globally. Now, we are disproportionately affected for us who are in Kenya, being among the countries in the low and middle income countries. And our mortalities, morbidity related to this disease is quite significant. I think it is only second among second to breast cancer among women. Now, it takes quite some time to prevent against to get, you know, cervical cancer once you have been infected with HPV, and that might probably give some insight to some of the people who might be in the call, who might not, who might be wondering why we giving girls the vaccine at the age of 10 years and all the way to 14 years. So the primary idea is that during this time that they have not yet engaged in any sexual activity, they should get a vaccine that is going to build their immunity against the HPV virus. Now, we are expecting that the solid evidence should be coming in around 20 to 30 years when it comes to the work that we are currently doing, and we are hoping that we are going to be vindicated that we actually, did the right thing. But I think as we talk about cervical cancer, it is going to be important for us to remember that vaccination itself is not the only solution, to the menace that we have with cervical cancer. So we always talk about this 90-70-90 strategy, where we want to ensure that 90% of the girls are vaccinated against the HPV and 70% of women who are aged between 35 and 45 years undergo, a screening with a high performance test against HPV, and 90% of those who are unfortunate to get lesions related to cervical cancer should be at least put on treatment. Now, our current state in the country is that we have around 6 to 9 years experience with the HPV vaccine. Previously, it has been given in 2 doses, that is between the years 2019 and 2025. And we are now the country is now right to switch to a single dose, but we are still maintaining the opportunity for us to give girls who might have missed on the primary vaccination point, that is the 10-year-old girls, to get their doses. That is girls who are going to be aged between 11 to 14. But we are insisting that should be strictly a catch up for intents of a catch up. Our main delivery strategy for HPV has been, the vaccine is usually given at a fixed permanent post. That is the health facilities that we have across the country. We have around 8,500 facilities spread across the country that are currently giving the vaccine. In quite a few instances, quite a number of instances actually, we have had outreaches that have been going to schools. That is the temporary fixed sites where probably some of your children might have ended up with a HPV vaccine. But we still insist that these vaccines are available at the primary vaccinating points, that is the health facilities. So you don't need to wait for the girls to, the people to come to the schools, so that the girls can get their opportunity to get the vaccine. You can simply walk into any dispensary in the country and you should be able to get the vaccine. So that is the details. Some of you are a health practitioner. Those are the details of how the vaccine is given. This is the vaccine that we are currently using in the country. That is Gardasil. It's a quadrivalent vaccine. And so we are just highlighting that slide that basically we are going now to be switching the immunization schedule from 2 doses to 1 dose. It is important, like Dr. Tabu pointed out, to remember that this is one of the most expensive vaccines that we currently have in our portfolio. So I will jump these slides on the rationale for the 2 doses for the single dose. The comparison has been done by my predecessors quite on this, but I will want to emphasize 2 things: that we can avail the evidence that you might want to peruse in detail that is related to the work that we are currently doing. and insist that the basis for these changes that we are making is grounded in solid scientific evidence. On the screen is basically a comparison of the the sero prevalence of antibodies that are needed to basically protect against the two strains of HPV that usually cause cervical cancer. That is HPV 16, HPV 18 on the top. So with two doses, with one, we are single dose. That is on the you should be able to expect that probably we are able to generate enough antibodies to prevent against to protect our girls against cervical cancer. So the Kenya has been lucky because some of this evidence has been actually collected locally. We have had the opportunity to participate in some of these trials. One of them was the Kenshi trial that happened some time back, and then we had some bit of modeling that was also done to evaluate the cost effectiveness of the country moving from a single dose to from a two dose to a single dose vaccination schedule. And the results show that probably we should be having quite some bit of savings also coming in that can be channeled elsewhere to make sure that all girls end up getting vaccinated. So our main focus as a ministry, as the National Vaccines and Immunization Program, is now going to be to ramp up vaccination so that we can attain at least 90% coverage, which might have not happened with the two doses, without the two doses in the past. So those are the other benefits that we have been talking about. So the key message is we are now going to be giving a single dose. We are targeting girls who are aged 10 years. We are going to still be availing, the vaccines to girls who might have missed the opportunity to get vaccinated at 10 years, and they will get the vaccines that is girls aged 11 to 14 years. For immunocompromised, girls, for example, who have HIV, they should be we should maintain the current immunization schedule that is recommended. That is 3 doses. That is given 6 months apart. And most importantly, we really are saying that the vaccine is safe to use. Now, one of the questions that came in when we were introducing the typhoid vaccine was, and I think this is important to mention in relation to the HPV vaccine, was how safe was the vaccine? We ended up giving close to 16 million doses of the typhoid conjugate vaccine, and I can confidently tell you that most of the adverse events that were reported in the country related to this the typhoid vaccine were not serious. We have now 9 years of experience now with the HPV vaccine, and we have had minimal safety issues that have been reported to us and to our sister program, that is the Pharmacy and Poisons Board, related to the HPV vaccine. So you do not need to worry about issues related to safety of this vaccine. Now, switching gears quite a bit on malaria, there is a lot of work that has been done on the epidemiology of malaria. Has been one of the main killer diseases that we have had for quite some time, but we are happy that the numbers are going down. And what is important is that if you notice that in the chart, since the year 2016, there has been quite a significant decline that is partly attributable to the introduction of the malaria vaccine in the country. So the next 3 slides are going to be highlighting basically the areas where we are currently doing the malaria vaccination. We introduced the first instance we introduced the malaria vaccine was in 8 counties, in around 26 sub-counties. Those are the sub-counties which are listed there. They were selected on the basis of the epidemiology of malaria. So basically, they were the sub-counties that had the highest burden of malaria in the country. Later on, of course, we expanded that to another 26 comparator sub-counties. And right now we are talking about expanding that to 3 to 8 to 12 more actually sub-counties. And the basis of that is still the similarity of the disease burden in these sub-counties with the sub-counties which are already vaccinating. So we are going to be switching the formulation, the RTSS that was alluded to by Dr. Zimba to a new formulation that is now called the R21. So key differences is that basically there are two different formulations, probably bioengineered differently. But most importantly, we are still emphasizing that we are still going to be maintaining the immunization schedule. Now, the vaccine is usually given in 4 doses. The first dose at 6 months, the second at 7 months, the next at 9 months, and the final dose at 24 months. So it is usually necessary for the children who are eligible for the vaccine to get all the 4 doses so that they are they get solid protection against malaria. So I will jump these slides on the rationale because this has already been spoken about. And finally, just make a few points on the issues that we are having with polio. Now, historically, of course, polio has been quite problematic in the country. And polio vaccine was actually one of the first 4 vaccines that was introduced. The others being the measles vaccine, the BCG vaccine, and then the tetanus vaccine. Now it has been quite a journey for the country because at some point in the year 2005, for some of you are old enough to remember, we might have you might have heard the term that Kenya had been declared polio free. That was true because we did eliminate the wild type polio, but unfortunately thereafter we started getting imported cases of the vaccine derived polio. Now that has now informed the necessity for us to change gears and now emphasize on introducing a second dose of IPV that is now basically able to protect against the 3 subtypes of polio, that is the type 1, type 2, and type 3, unlike the OPV formulation, that is the oral formulation that only protects currently against type 1 and type 3 polio. So in the long run, we are hoping that we should be able to get rid completely of the vaccine-derived polio. And when that time happens, hopefully the country should be able to move to a situation where we are only going to be having the of polio to prevent against IPV. But OPV is quite immunogenic, and it is actually a savior for us as a country right now, as we struggle with the issues that we are having with polio, especially the imported cases that we are having across along the borders. In the long run, we are hoping that we should be able to do away with these cases and switch to the inactivated polio vaccine completely. So I think that would be the end. But finally, I think one more slide on what we have done so far with these switches. Now we started on this journey quite some time back. 3 antigens, quite some heavy work, and it's also coming up in the year that we actually introduced the typhoid vaccine, and we did quite a huge quite some huge amount of work, vaccinating close to 20 million girls with close to 20 million children with the typhoid vaccine, and as well as close to 7 million children with the measles rubella vaccine in July. Now we have been able to do successful grant applications to our partners, mainly Gavi, and they have been able to support us with the basics that are necessary for us to do this work effectively. One of them is the national training that has already been done. We are hoping right now, as we speak, teams are out there in the counties doing cascade trainings for the counties that is supposed to be taking a week. We are hoping that immediately after that, with the feedback that we are going now to get from the counties, that should inform on the exact dates that we are now supposed to formally now do away with the 2 doses of HPV, start doing the 12 extra sub-counties with the malaria vaccine, and probably also start doing a second dose of the IPV vaccine. Thereafter, probably in the coming year, we should be having the supplies available to the country for the malaria R21 formulation, and we are hoping that when that time comes, of course, we are going to be getting the necessary support from you people to be able to effectively roll this out. So I think that would be the end of my presentation, and thank you very much. Back to you, Christine.
Thank you, Dr. Wesley. That was quite clear. I could see people appreciating on the various antigens, and now we will come to the Q&A section. I have tried to compile the questions that were asked, and I will ask as per speaker, and I will start with the first speaker. I know we had another speaker, Dr. Langat. Dr. Daniel Langat was our next speaker. He works with the Ministry of Health and is very key in disease surveillance, outbreak response, and health information systems across the country, and has been very, very instrumental in Kenya's polio eradication strategy. Unfortunately, he would not be able to attend. Last-minute emergency for him to address on an outbreak that is currently happening in one of the county on cholera. So he rushed there. He will join us in the next session. We are hoping to have another session next week where he can give us the journey of the end game strategy. Now, coming to the questions, I will start with Dr. Boston Zimba. Dr. Boston, there was an anonymous person who asked, what's the clinical significance of both OPV and IPV vaccines? And when is it too late to catch up vaccines for the two, the OPV and the IPV? I think he talks about the eligibility criteria on when a late child can be given the vaccination. Then the other question is on till what age is the single dose valid for? For example, those that were due for second dose, will they still get the second dose now that we are switching to HPV vaccine single dose? That is the next question. And there was another question on from Edward that he is asking, United Nations confirms US will leave World Health Organization in 2026. So how will this affect the funding of the many health projects around the world and even the availability of vaccines, medicines, and other supplies for the vulnerable population? Dr. Boston, please try and respond on that. Thank you.
Thank you very much, Christine and colleagues. Very, very good questions and very relevant. Let me start with OPV and IPV. I think when say clinical differences, I think maybe let me just give a perspective in terms of the differences between the two. So OPV and IPV. I'll talk mainly about the OPV that we're currently using, which is called BOPV, bivalent oral polio vaccine, which contains two serotypes of polio, type 1 and type 3. IPV that we're talking about is trivalent. It contains 3 serotypes of type 1, type 2, and type 3. So already you can see the difference. OPV, it's live attenuated vaccine. So which means it's a live vaccine. The virus is still live. It still has life. IPV, it's killed. So what it means is I mentioned that within the region, if you see, I think we eradicated polio, including type 2 by 2020. And I mentioned that most of the paralysis that we're getting, most of the polio outbreaks that we're dealing with in the region, not most, all of them, are circulating vaccine derived polio virus type 2. What does that mean? It means these are vaccine variant. It means these are virus that were from the vaccine reverted and caused paralysis in a child who was not fully immunized. So that can only happen in live vaccine. In inactivated vaccine like IPV, it cannot cause that. So already you can see why within the polio endgame strategy, we are pushing towards use of inactivated polio vaccine so that by the end of the day, we want to control or we want to eliminate even the circulating derived polio vaccine. I hope that is very clear. And in terms of the how we deliver this vaccine, OPV, we usually give oral. So it's like a dot in the mouth. What's this IPV? It's injectable vaccine. So in terms of clinical difference, mainly we are talking about, since one is live, one is inactivated or killed. Obviously, the killed one cannot cause any problem, even in individuals that are immunocompromised. That's number one. Number two, we are talking about at what age can you continue or is single dose. So if you look at the strategic advisory group of experts, they looked at several scenarios actually. The initial recommendation goes to girls actually between 9 months and 14 years. But there were some additional information where they shared that actually it's more cost effective to give HPV vaccine to, should I say, women or girls up to 20 years than to give boys between 9 to 14, because there are other countries where they give both girls and boys, because HPV vaccine does not only protect from cervical cancer, it can also protect you from head cancer, neck cancer, and other one. But the main problems, main issues are cervical cancer. That's why in most of the countries the primary recipients are girls, but there are other countries that they are able to buy enough vaccine for themselves, they also give it to boys. But also the least rationale is because boys are the carriers of HPV virus. So you'd also want to protect them. Anyway, but to answer your question short, in this case, it is applying to all the women up to 20 years. However, all the should I say, girls or women who had received a single dose. I think Dr. Tab will come in into this, but now the recommendation is they do not need to get the second dose as long as they had received the first dose. That's fine. You have seen the evidence that was shown by Dr. Wesley. Just to explain that a bit, in immunology, in vaccination, we talk about two things: seroconversion and seroprotection. So, if a vaccinee, somebody who has received the vaccine, has developed enough immune response, which is seroconversion, but enough to protect you from disease, seroprotection. In other vaccines, there's what we call surrogate of protection. So, surrogate of protection, it means there is already a marker or a level of antibodies at which if any person has received a vaccine and is able to develop antibodies up to that level, they are assured of protection. That's what we call surrogate or what we call correlate of protection or surrogate of protection. However, some of these vaccines we don't have. So what it means, with some of the vaccine, we do not have an indication to tell how many geometric mini titer do we have to produce for us to be protected. But for BCG, we have. DPT, we have. So until we have that, then we'll be able to say either it's a single dose or the 2 doses or 3 doses. As long as once you get this, you're able to develop antibodies up to that level, you are sure of protection. Let me go now to the issue of financing. United States of America, they I will not talk about UN in general, but I'll talk about WHO because they had formally written to WHO HQ that of their intention to pull out from World Health Organization. Obviously, the impact is huge. US is one of the biggest funders, not just to WHO, but to many organizations. And I think it's not just to WHO. If you look at, I don't know if you have read the US first policy in public health. I think I can share with you. They have developed United States of America first policy. So it means almost all the intervention, whatever, their priority, their primary objective first is US. Is it benefiting US? So under the closure of USAID, you saw so many programs, so many organizations, so many what affected. This is one of the biggest challenges that public health are gonna face in the near future. And it's not just US. We have seen right stream political parties in different countries that are advocating for nationalism. Nationalism, we're talking about trying to focusing and protecting their population. We see that is happening a lot in Germany. We see aid being cut to health organization from Finland, Netherlands. So as more and more countries are trying to cut aid, not just WHO, but to health organization, we should expect more and more challenges for us to be able to tackle on the health challenges that we are facing today. And this calls upon mobilization of domestic resources. So it means all of us, we need to make sure that we are advocating to our governments wherever we serve, wherever we are, advocating for more resources, for government to allocate more resources to health so that we should be able to maintain the gains that we have already gotten. I think Dr. Dabu will tell you that even Gavi has been affected as such. If you've been following all the intervention of doing, you see that even the support that Gavi to countries is also being reduced. So these are clear indication that something is wrong in as far as financial resources is concerned. So in our meetings, in our programs, in our trainings, we should not just be focusing on climate change as the next global pandemic, but we should also focusing on financial challenges as another global pandemic that could affect almost the health interventions, and that could lead to revert or resurgence of the diseases that we thought maybe we have already been dealt with. Think about HIV, think about malaria, think about TB. If these drugs are going on hold because of the resources, what will happen? And then think about immunization and all these other stuff. So I'm sure this is a general question that a particular tab you can come in also maybe to say one or two things on this because it's almost general. Thank you.
Thank you, Dr. Zimmer. You have comprehensively responded to the questions. Participants, I kindly request for a few of your minutes, considering we had a technical hitch to be able to address to your questions. Now I go to Dr. Tabu. Dr. Tabu, the question that has appeared most in the Q&A area is about the number of vaccines given to a child. Are they not too many? And then the second one is, what are we doing to address vaccine hesitancy for HPV vaccine? And there's someone who has recommended if we would go the school strategy, which is most effective because its targeting approaches. We know the girls are in school. Dr. Tabu, over to you.
Thank you, Christine. I have attempted to respond to most of the questions in the chats for colleagues who have who are on the call and they've asked the questions, of course, cognizant of the time. But just to share with you that since time immemorial, we have seen a decline in vaccine preventable diseases. We see less and less children dying from vaccine preventable diseases. We see less and less children getting disabled from vaccine-preventable diseases. Should we then stop our trajectory and worry about the number of vaccines and let ourselves slide back into disability and death? Maybe not. The concerns around the vaccines being too many, this is just to reassure you that before a vaccine is introduced, one of the things that is looked at very closely is the potential for co-administration with other vaccines. So this is normally one of the biggest agendas. Number two, this also is related, the issue of co-administration is also tailored so that we minimize the number of visits that the caregiver has to make. This therefore minimizes the costs to the healthcare system by minimizing the number of visits, but also the costs to the caregiver, because remember, they have to give up work, they have to find resources to travel to the health facility and bring this particular child for vaccination. So knowing very well that these vaccines can be administered without any increased risk of AEFIs, adverse events following immunization, is the reason they're given together. Of course, as we move on, and like Dr. Boston did share earlier, there is advancements that, and with increased vaccine availability, some of the vaccines are going to be combined into multivalent formulations. But as we move on also over the years, there'll be new technologies that may be non-invasive for some of the vaccines, perhaps as patches or otherwise. But for now, we have to stay true to our children. We have to stay the course to protect our children from vaccine-preventable diseases. In terms of the issue around vaccine hesitancy, and not just to the HPV vaccine alone, immunization program basically has everyone, all of us as stakeholders. You cannot potentially or possibly run an immunization program without engaging academia, without engaging scientists, without engaging the communities, without engaging public health experts, without engaging religious leaders, without engaging the educational system, and so forth. So the realm of combating vaccine hesitancy is really robustly engaging all of the stakeholders within the country to build confidence, build trust, and make sure that they're involved in immunization programming. So much more specifically, we have had active monitoring of the discourse around vaccines in media, alternative media, and even in public engagements. And based on that, the sentiments are noted, and based on that, the engagement of the communities does happen. Defining new vaccines, we have active community engagement bulletins that engagements that go on. We also have a strong engagement with the Ministry of Education. At the launch of the HPV vaccine, you may realize that this was done in 2019 in Mombasa by His Excellency President Uhuru Kenyatta, but in attendance was the Chief Kadi and the Archbishop of the Catholic Church in Mombasa. So at the time, it's just to reassure you that we have had engagement of the religious leaders also enlisting their support to be able to protect our girls from cervical cancer. This continues. It's not a one, it involves a behavior change, which you all know takes time and is a process. It's just like has happened for HIV and other components of prevention. In terms of and of course, we have other things about capacity building for interpersonal communication. We have had mass media engagements. We have webinars like this in which we seek to answer all of your questions. We have social media presence, and we also have announcements through the mainstream media. So, but we're able to share specifics if you wish to then reach out. In terms of the strategy for vaccination, of course, the most ideal strategy that would give us all of the highest potential or possible coverage for the HPV vaccine will be the school-based strategy. We do acknowledge that at 10 years, grade 4, it was chosen because this is the age at which we have the highest school enrollment at 95%. So potentially, this was expected to mirror the coverage. We, however, did a pilot ahead of the HPV vaccine introduction in 2016 in Kitui County, and also did some studies within the country that whereas this delivered very high immunization coverage, the cost of delivery of the vaccine was unsustainable. It basically would be something like more than 4 times the cost of the entire immunization program. So just like for the other vaccines, basically is to have the delivery in a hybrid model where we do have a delivery within the health facilities, but with a targeted and periodic targeted community level and school outreaches, which are planned for, organized and owned at the community level, just as a process of encouraging the ownership of the immunization program at the community level. And if I may say so again, and mirroring the other routine vaccine antigens, the government does provide the vaccines closest to the communities through the health facilities. Then the caregivers take ownership by availing all of the children to the health facilities for vaccination. So this is expected to mirror for the HPV also, that we have joint ownership between the government and the communities for protecting the girls, so that the community is wholesome and able to demand the services as should be. I think I want to leave it there. If there's any burning question, please also, and through Christine, our moderator, feel free to reach out. The webinar may be short, but it's not the end of us responding to your queries. As usual, we're on standby to be able to respond to all of your concerns, queries, and be able to engage further, even on topics of concern. Thank you.
Thank you very much, Dr. Tabu. As you have put it, we are going to compile all the questions that we have received today and ensure that we package them well to communicate next time. Feel free to reach out to the National Vaccines and Immunization Program for concerns and clarification. Now we come to the end of our webinar today. My call to action to every one of us attending this meeting is that we join forces. Let us amplify accurate information, factual information to those that believe and trust in us. Let us engage communities. Let us sustain vaccine uptake in where we are. These changes are not just technical updates, they are opportunities to build our trust. Communication is about trust and confidence, and for us to be able to close the equity gaps, to protect our future generation. So your role is very key, sharing information in all the networks, in our community, in our families. Together we can ensure that every child, every adolescent, and every family benefits from this life-saving vaccine. I want to give a vote of thanks to KNHUON through Nelson for giving us this space, Ruth from Perth for the planning of the webinar, our National Vaccines and Immunization team for putting together all the messages and the talking points, and WHO, UNICEF, and other partners working closely. Also, all our participants and where you work, we are grateful. I want to hand over to Nelson to wrap up. And Nelson, please, there was a question from Rosemary, whose concern was her CPD accreditation in her licensing body are not able to see whether she has attended the webinars. Kindly help in ensuring that she's able to show her attendance in the webinars. God bless you. I was your moderator, Christine Meno from National Vaccines and Immunization Program. Over to you, Nelson.
All right. Thank you, Christine and the NVIP team for your presentation. I'm just trying to locate Rose's question, but just to be clear, Rose, kindly email KNH webinar@knh.or.ke, attention to Nelson, I'll be able to pick it up from there. I can't be able to see the question from my end, but we'll be able to assist you or to see why you haven't been able to receive your points. So kindly do that. Remember, Rose, if you're in the meeting, kindly email knh@knh.or.ke, attention to Nelson, and I'll be able to follow it up from there. Thank you once again for joining us today. We apologize for the technical hitches along the way, but we've been able to finish. This team will be back early next month on 4th for another session. So do kindly join us for the same. Have a wonderful evening. Thank you.
Thank you, and bye-bye, everyone.
Thank you. Bye.
Thank you. Bye, everyone.